So good morning, everybody. I'm still having trouble going live on Facebook. So I'm doing this from the personal page instead of the Health Without Risk page. It did let me on personally, um, but where I originally planned on doing this. So I'm 3 minutes late. Sorry. Good morning. It's rainy in Boonville. Like most old guys in coffee shops, I guess I always talk about the weather first. So it's kind of cold and rainy. Oklahoma got stomped on yesterday. Fortunately, all of the tornadoes didn't make it up here. Morning, Eileen. We'll hopefully have a few more people show up. I'm going to get started though. So we've been talking about the health effects of social isolation and being protected, staying in place, and we talked about the effects on your immune system. And I gave you some strategies for fixing that or hopefully boosting your immune system during all this. Whether you're on the open up versus stay isolated camp of this pandemic right now, there are some health issues, and a lot of them have to do with your immune system. So one of the videos that's been taken down is from Dr. Erickson and his partner that run an urgent care center in Bakersfield, California. Good morning, Terry. How are you? Holly, Linda, John. Thanks for coming. So that's been taken down, but I saw another one with apparently part of that news conference that he did, he and his partner, specifically talking about the reduction in immunity that's going to happen. So he's talking about wait for the October surprise, because the longer we're isolated, the potential health effects to your immune system may keep you from fighting off things, specifically the rejuvenation of this coronavirus, which they seem to think is going to come roaring back like the swine flu did this fall. So the swine flu actually was worse in the fall after the initial outbreak in 2009. So I'm not going to spend the whole time talking about coronavirus and COVID-19 because people are probably tired of hearing about it. However, we're going to talk about some age reversal techniques that you probably haven't heard of. Okay, so I've talked to you about my shining protocol, and last week we talked about sleep and how to maximize that in the natural way. So what we are moving toward is the H part, which is hormone balance. This isn't the whole part of the protocol that I use, but it addresses hormone balance as far as aging. So as an age management doctor and a hormone doctor, I think hormones make the world turn around on its axis. And I really think that aging has a lot to do with hormone or suboptimal hormone production, which starts when you're 40. Men, testosterone starts reducing at the age of 30 at 1 to 3% per year. So hormones are a big deal, and they have to do with aging. This particular study talks about growth hormone, and growth hormone's been talked about or been researched by the guy that started the American Academy of Anti-Aging Medicine, or A4M, about 28 years ago. He wrote a book called Grow Young with HGH. You can still get it on Amazon, and I'm blocking the guy's name, but the A4M people have been studying this. Hey, Rochelle, Amanda, Megan, wow, Jean, Debbie, nice to see you all. So they've been studying human growth hormone and regeneration of the thymus gland for almost 30 years, really. This thing I'm going to talk about here in a little bit is really one of the first human clinical trials. It's a small one. It's a small study, so it needs to be studied further, and they're working, and they're doing that, actually. Okay, so there is a difference between chronologic age and your epigenetic age. Okay, so, or a biologic age. So this study used epigenetic markers to show that there's a reversal in aging in the protocol they designed and worked on for about 2 years. So epigenetic aging is measured by there's several different models for that, but methylation of DNA or tagging of DNA by methyl groups or chemical alterations is how they determine an epigenetic age. So you can be 59 like me, but I might have an epigenetic age of 51, or I might have an epigenetic age of 72. So your chronological age is just a number. And of course, that's, of course, mind over the number. So I'm 59. I feel like I'm 25. I just, in the last 3 or 4 years, I've kind of felt the fact that I'm older. And so not all of what I talk to you about I've done, but most of it. Okay, so in 2008, I started using platelet-rich plasma, which is a stem cell treatment. It's not a drug. You're using a person's own plasma and platelets to rejuvenate tissue. And I used it in gynecologic surgery after having a conversation with a platelet-rich plasma representative in the surgical lounge at Midwest Regional Medical Center. She was there providing platelet-rich plasma to a buddy of mine who's an orthopedic surgeon, and he would use platelet-rich plasma during hip replacements, etc., and also inject it into elbows and knees in the office to regenerate tissue in a natural way. And she told me about that, so I researched it. PRP was first used in cardiac surgery in Italy in 1987. Especially during coronary artery bypass graft, and then it moved into orthopedics. And since it was not a drug thing, I decided, since I was a pelvic reconstructive surgeon, so prolapse surgery, that it would be interesting to use platelet-rich plasma in surgery. So I did that. So this young lady would come and we'd draw blood and give it to her, and she would generate her platelet-rich plasma and give me 2 syringes of 10 cc's. And after I sewed everything shut from vaginal reconstruction, I would inject 10 cc's of platelet-rich plasma into the wound, in the vaginal wound that I'd stitched up. So you can see all these stitches, this, that, and the other thing. And I would stick that stuff in there. And I did my own little clinical trial to see how that would work. So I asked patients before surgery, are you willing to do this? It's going to cost you $500 out of pocket. Some did, some didn't, and I just compared the two. So 2 weeks after surgery, if I did a vaginal exam with a speculum on somebody I'd operated on, so the ones that didn't get platelet-rich plasma had stitches all over the place, and you could see the wound trying to heal. The ones that I had injected platelet-rich plasma with, you could not even tell I'd operated on them. They just had a normal-looking vagina. All the stitches had dissolved. The tissue had healed, and that led me into the cosmetic part of platelet-rich plasma. So I trained on that in Alabama under Dr. Reynolds, who made the vampire procedures kind of worldwide famous. So that is one aspect of age reversal, where your own platelets, which are stem cells, generate new tissue and decrease inflammation and wound heal. So that's the whole point of that. So if you could do that just with an injection, the question is there a way to rejuvenate your body? Platelets kind of do it, but you can't just inject platelets all over your entire body. So is there some protocol that could be used that would reverse aging? Well, it turns out there kind of is. Okay, and so this trial specifically looked at reversing the aging of the thymus gland. So the thymus gland is where your immune system center is. You have and I told you this, I think, Friday or Monday. Your thymus gland starts out at age 12 about the size of a walnut, and by the time, so it's right behind your breastbone, your sternum at the top, and by the time you're 40, it's regressed to the size of a pea. So the thymus gland regresses, and it gets replaced by fatty tissue. And so one of the markers and measures that they use on this clinical trial is MRI resonance, so magnetic resonance imaging of the thymus gland right behind the sternum. And so when we talk about this, I'll show you, when we talk about the study, I'll show you or talk to you about what they found. So they did this study pretty well. It's just small, and it wasn't controlled. So you've heard people talking about Chloroquine and hydrochloroquine don't have double-blinded, placebo-controlled studies for treating the coronavirus. That's true. That is true. And so this one, this study needs to be done on a bigger population. So the guy that did it, one of the guys, it's Greg Flehy, and I hope I didn't destroy his name. I don't know him, but he was one of the guys that did this study at Stanford in California. He began studying the thymus regeneration possibilities in 1986 when he read a paper where scientists were taking growth hormone cells and injecting them into rats, and they found that they could rejuvenate their immune system. And he got thinking, well, why hasn't anybody tried that as a clinical trial? You're not doing anything weird. Although growth hormone is only FDA approved for treating dwarfism. So the doctors that use, and there's doctors that use growth hormone for regenerative and age management medicine, but they're off label. So theoretically, they could get in trouble. I do know a plastic surgeon friend of mine in Oklahoma City that's been giving human growth hormone injections to her patients for 13 years. Thinks it's great, gets great results from that, etc. Okay, so that was his impetus, if I said that right. Impetus? I can't remember. I am from southern Missouri, so. So he called his trial the TRIM trial. And I'll post the link for those of you that like to read science. And I don't know if Tammy Crabtree's on here, but she likes to read science. I'll post the actual article in the comments when I get done. Morning, Jean. Debbie's, Andrea, Rob, hey, Rihanna. So, Christy, the TRIM trial stands for, sorry, I'll look down, thymus regeneration, immunorestoration, and insulin mitigation trial. Okay, the article is posted in Aging Cell Journal in September of 2019. And I just recently heard about it in March, and I thought this kind of fits with what we talk about in class. So there are aging-associated thymic involution, like I told you about. So the thymus gland tissue gets replaced by adipose or fat tissue, and you can see that on a magnetic resonance imaging test. Okay. So thymic involution is related to disease. If your immunity goes down, you start getting chronic disease. And by the time you're 60, you may not have hardly any thymus tissue left. And sure enough, most of the diseases that are chronic that we get that eventually lead to our mortality happen after the age of 60. So there's one science guy that I read about that says really from 54 on, you really don't have enough thymus tissue in order to regenerate. So that's one argument about this study. So thymic involution is linked to increased risk of cancer, infectious disease, of course. Pneumonia, of course, is a fairly large mortality risk for people that are in their 70s. Think about how many people you know that died of pneumonia. And you don't necessarily hear that in people that are in their 30s when they've still got thymic tissue. Increased generalized inflammation, and I've told you chronic inflammation is the basis of most chronic disease. Okay, increased atherosclerosis, and increase of all-cause mortality just from thymic involution or replacement of the thymus gland. So the TRIM trial is the first clinical trial that was designed to reduce aspects of human aging. So most of them done before are in rats, of course. The poor rat gets stomped on the most before we start picking on people. So it is the first human clinical trial that's been published. Okay. The purpose was to see if recombinant human growth hormone was able to prevent or reverse thymic regression. Okay, he chose men from 51 to 65 years of age and put them through this clinical trial. It wasn't controlled, it's not placebo controlled, but it led to a bigger trial that's getting ready to start. So growth hormone can increase insulin levels. So there is some potential for diabetogenic or diabetes-inducing rises in insulin levels. So they used DHEA, which is dehydroepiandrosterone. We talked about that Monday for rejuvenation of or protection of immune function. And they used metformin, which is a very inexpensive and widely used medication for controlling type 2 diabetes and glucose levels. So the protocol involved human growth hormone administration that was individualized. So all these doses were individualized to each person in the trial based on their health history and their body weight, etc. So it wasn't just one size fits all. That's one of my problems with the pharmaceutical industry, is they'll come up with one dose and they say, well, that'll work on everybody, and that's not true. That's just not true. I know that from 30 years of clinical medicine. Okay, they followed a bunch of lab tests, okay, one of which was making sure that insulin levels didn't spike, so the metformin and the DHEA seemed to keep that from happening. When you're looking for people that may benefit from age management with growth hormone, you follow a lab marker called insulin-like growth factor 1, and it's made in the liver in response to growth hormone. They found that of course decreases with age, as does your growth hormone. And your IGF-1, you seem to get benefit from growth hormone optimization if your IGF-1 is less, well, they say less than 200. I always used it at 160 or less. The idea is to get IGF-1 levels. That's how you follow the response. Well, it's the best test for a response. I don't think it's perfect. But if you get an IGF-1 level between 200 and 300, that's the level that a person in their 20s has. So that's the goal for growth hormone optimization. So IGF-1 levels, they follow PSA levels in case somebody worried about inducing foci or little prostate cancer cells. So the PSA level they followed. They looked at C-reactive protein, which is a marker of chronic inflammation. They measured metabolic profiles, kidney functions, and they followed glucose levels and insulin. Okay, so what they found was, and this was a 1-year trial, so this protocol was for 1 year. And then they followed them for 18 months after that and then published. So no change in metabolic profile, nothing in albumin, liver functions and enzymes didn't change, glucose levels did not increase, insulin levels did not increase, and for kidney function, they actually found an improvement in glomerular filtration rate, which declines with age. So if you live long enough, your GFR seems to go down. In this study, it went up. Okay. What they also found was C-reactive protein levels decreased. So this is all statistically done. So they reached statistical significance. Their problem was that their numbers were small, which then led to let's do a bigger study. Okay, so CRP decreased, which potentially is a reduction in chronic inflammation. That's not the only test you can do for that, but that's one that is easy to do and is not, a lot of doctors do that. Test just to see if you got inflammatory cells in your body. Okay, the PSA, prostate-specific antigen, which is measured for risk of prostate cancer, went down statistically. So that PSA level dropped. And then the other one that they measured was testosterone, since they were doing men, no change in testosterone levels at all. Okay, so that was the lab, the lab results. Then for their MRI, the magnetic resonance imaging, they did a baseline study of the thymus gland and then studied it over time. And what they found was there was fat regression in the thymus gland based on the densities on MRI imaging, suggesting that there was functional thymus tissue that regenerated. Okay. In addition, they did immune markers. So they did a lot of immune stuff, and the immune system response improved. Okay, so specifically monocytes, and remember the elemental parts of your blood come from your bone marrow. So take your vitamin D and your calcium. Keep your bone marrow healthy. It's where you make red blood cells and white blood cells. Monocytes are the first attack device for inflammatory cells. And we've talked about generating oxidative reactive species and free radicals and their potential destruction of cell walls. So the higher your monocyte count, the lower your lymphocyte seems to be, because of an attachment of a compound called CD38. So and most monocytes have CD38 positive proteins on them. So the science behind that is gobbledygook, so I'm not going to delve into that much. But what they showed was that this one-year protocol decreased CD38 positive monocytes. And more importantly, it improved the ratio of lymphocytes to monocytes. So lymphocytes are your T cells and your IgG and IgM, which fight off disease. So monocytes are like the first response. And then over time, and like Dr. Erickson said, if you are not exposed to bacteria and viruses and you're socially isolated and you're disinfecting and everything, getting rid of all the bacteria and viruses in your environment, you're actually harming your immune system in the long run. And if potentially that goes on long enough, then your immune system doesn't know how to fight anything off. Plus, if you're older, your thymus gland has potentially been replaced by fat cells. Okay, so the increase in lymphocyte to monocyte ratio, which is an improvement, correlated exactly with the regeneration of tissue and replacement of fat on the MRI of the thymus gland. Pretty interesting. So that insinuates that that's coming from the thymus gland, okay, that lymphocyte improvement. Okay, and even after they stopped the study, the leukocyte-monocyte ratio and the functional tissue of the thymus gland seemed to stay there. It did regress eventually, but it seemed to stay there for almost 18 months after they ended the study. So if you're in a study, you're a guy that got better, you'd be like, well, can I just keep doing it? Which led to the bigger study. Okay. Interestingly enough, the epigenetic age factors based on the methylation of DNA model showed regression on average of epigenetic age by 2.5 years. So those people became biologically 2.5 years younger on average. And that seemed to be length of treatment related. So the first 9 months of treatment, the average regression age was minus 1.68 years. And then in the last 3 months, so month 9 through 12, the regression analysis by epigenetic methylated DNA was minus 6.48 years. So that kind of insinuates that the longer the treatment, the more accelerated the regression of your epigenetic age and your biologic age is. So again, this is the first clinical trial in human beings on a small scale that showed you can actually regress biologic age. Okay, so now they're designing a large one. I'll tell you about that in a minute. So what does increasing lymphocyte to monocyte ratio mean? Well, what it shows is that there's a better prognosis for 8 different types of cancer, prostate being one of them. It improves atherosclerosis, or regresses. It improves cardiovascular disease. It improves stroke. And there's less generalized inflammation with an increase in your lymphocyte to monocyte ratio, which this study proved happened statistically. Okay. Okay, what does CD38 do? So if a monocyte is positive, has CD38 positivity, that combination destroys a precursor to NAD. So NAD is nicotinamide adenine dinucleotide. I'm a chemistry major and I still have to look at the words to make sure I say it right. So NAD is what provides functionality to mitochondria. And if you remember biology, mitochondria is the powerhouse of the cell. So the energy source for cellular metabolism is ATP, adenosine triphosphate, which is produced in the mitochondria under the direction of NAD. So NAD is required for life. And CD38 positivity decreases and destroys the precursor for making NAD. Okay, so there are ways to supplement NAD. You can take NAD, but this is a way to actually get rid of the pathophysiology of what monocytes and inflammation can do to the tissue, specifically the mitochondria, the powerhouse of your cell. Okay, so CD38 arises in the inflammatory cells of tissue. So that's way more immunology than you probably want to know. But that's again, I'm still going to prove to you that chronic inflammation makes you sick and leads to chronic disease, most of which can probably be reversed. Not everything, but most. Okay, so theoretically, that suggests that if you decrease CD38 positive monocytes, you're going to increase your natural NAD because you're not destroying the precursor. Okay, so these positive results, so on a small scale, very small scale, indicate that a larger study is needed. And of course, you're going to hear that from every study that says, oh, well, more studies are needed, blah, blah, blah. I get that. The more that are done, and that's how hypotheses become theories, if several different people or a lot of different people can reproduce the same results of a study, then it's probably true. Okay, so what they've come up with is a new human rejuvenation trial, and they're involved in research and raising money to be able to do this. And they're screening people for that trial from another trial called Vitality and Aging Interventions Trial. So this is all going up. If I can find the way that you can look at it or potentially sign up, it's not a trial where they pay for everything, and I'm not suggesting everybody do it, but this is kind of an exciting little research thing among all the doom and gloom that we've been hearing for the last 3 months. Okay, so the trial is Vitality and Aging Interventions Trial, which is what they're designing and looking for screened individuals that meet the criteria for the study, and they're screening with a trial called Vitality and Aging Longitudinal Study. Okay, so there's a big, huge, enormous number of labs that are done to see if you meet the criteria and whether or not you can enter that trial. So the trial is designed sort of like the Framingham Heart Study, which you may have heard of. It's been going on since 1948. I think they're in the third generation of people from the Framingham Heart Study, which led to all of the information about how to prevent and avoid cardiovascular disease, still the #1 killer of Americans. So human growth hormone, most doctors would not write it. However, there's a way to safely get human growth hormone optimized. So there are several releasing hormones, which are called human growth hormone secretogs. So they work by feedback inhibition. So in other words, if you take a human growth hormone releasing hormone, so the two I'm thinking off the top of my head are sermorelin and ipamorelin, that have been used now for about 5 or 6 years for optimizing growth hormone levels. Because if you just give growth hormone, you got to know what you're doing. It has to be individualized, or you wind up Andre the Giant, who had a genetic human growth hormone excess levels, and he died at 41. So human growth hormone can be overdosed and has some side effects and potential problems. If you use a secretog, once your growth hormone is optimized, it sends a signal back to the pituitary gland to stop making it. So you can actually not overdose or get too much growth hormone if you're using a releasing hormone. And like I said, that's being done by age management and functional medicine doctors all over the country. It's a much less expensive way to get your growth hormone in good shape, or growth hormone levels in good shape, because growth hormone is expensive, $2,500 a month. The releasing hormones usually $200 to $300 for 30 doses. So this is, They used recombinant human growth hormone in this study. I don't know if they're going to use the growth hormone secretogs in a different study, et cetera, but there's a fair amount of research on sermorelin and ipamorelin. So I thought what we'd do is talk about something fun and exciting today, and not a whole bunch about COVID-19. However, we will wind up talking about some information that I ran across from an epidemiologist on Twitter, who suggests that we shouldn't be focusing on mortality rate. And we talked about the pandemic within the pandemic last week or the week before, but the potential things that, other than death rates, that should be measured about the COVID-19 pandemic from an epidemiologic standpoint. So it's kind of interesting. So I'm going to put that together, and we'll do that Friday morning at 9:30. Okay, so thanks for joining. That's all I got. Peace and health to all of you, and be thinking about your immune system. I'll see you Friday. Bye-bye.